Thank you so much for that kind introduction. And yes, I am trying to make an honest living today. So I'm going to skip through this very quickly. I didn't do a top 10, but I have a top 10 minutes, so that's about all I have. So that'll be the way I'll approach that. I want to start by saying that we spent a lot of time over the last few years, everyone building predictive analytics into everything. You can build it into electronic health records for sepsis, clinical deterioration. We have things here that predict malnutrition. But one of the things that I want everyone to be very cautious about is that when we create our models, when we train our models, we often train them on data sets that have inherent biases. And the reason is, well, it's pretty clear. For many centuries, since the medicine first became medicine, wealthier people have better access to healthcare than poor people. And so we have to be cautious that we don't introduce bias into our algorithms. And so we intentionally test our algorithms on different subsets of populations here as one of the underlying principles. The other thing I want to point out is that we can introduce a confirmation bias. We'll call it an automation bias, is sort of the new term. This is an example of where radiologists were getting advice from an algorithm that helped them grade mammography in terms of the grade of cancer. And on the left side, the AI suggests a correct category. And whether you were on the left, inexperienced, meaning a resident, in the middle, a junior attending, or on the right, an experienced attending, you were probably about 80% chance of getting it right. But then as soon as we started introducing, or in this study, they introduced intentional errors, the residents were only 20% likely to get it right, the inexperienced attendings 25%, and even the experienced attendings less than half than likelihood to get it right. So the obligation is to be not biased, and the obligation is also to be correct, because if you're incorrect, you're going to lead people astray, and that's bad. And then the next one is workforce. We work very carefully with frontline providers when we develop new tools. And it is incredibly important to do so. This was outside, I believe, Kaiser Permanente headquarters, California Nursing Association. And these are going to be huge upheavals in the future. And the only way to get your hands around it is to say to our nurses, to say, we don't want any AI at Mount Sinai. It's like, well, we have about 25 AI products clinically that are already in the background. And we work with our frontline nurses to make sure that they see them as positives if it makes your life better. But when we get to the future where AI might start to change or alter positions, then we're going to have to really considering things. So let's talk now about how we might leverage the AI to become the world's safest health systems. The first thing is the concept of quality. So the Consortium for Healthcare AI, or CHAI, has developed the concept of an insurance laboratory, and they're starting to work with Joint Commission. So in the not too distant future, there are probably going to be entities, I hope Mount Sinai is one of them, that will be able to test tools, algorithms for quality, safety, absence of bias, and refining the products to fit best in the workflows. And also, frankly, to create revenue streams for these organizations to invest in the innovation. And I also want to point out the issue of advocacy. Where you have CHAI aligned with Joint Commission, the physicians need to be at the table in Washington and state capitals, aligning government regulation with the concepts of assurance lab certification, expanding access to care through agentic extenders of licensed providers. That's an entire change in scope of practice, but getting the tools out to more people in rural areas, even in urban areas, are very important, but with the caveat that we shouldn't have computers as the only access for poor people, and you have to be wealthy or well insured to see a human. And then the final thing is rational regulation that protects public safety, but doesn't hamper us from innovating in the interest of actually improving public safety. Robotics is something I'm just going to skip over fairly quickly, but it may not be so much in the realm of clinical cardiology practice initially, but a lot of the support services in hospitals, things like delivering of supplies, cleaning of floors, things of that nature will probably be changed somewhat radically. I want to talk about a couple of agentic AI use cases. An agentic, well, you think of an agent. So now we have large language models, but think of the agentic tool as an interface between a large language model and the clinician or the patient. And what we have here is an example of where we applied it. Our overworked and under-rested surgical residents are tasked by the department with doing an analysis of every surgical complication. So let's say there's an anastomotic leak. The resident has to go through the record and find all of the things that might have gone wrong and write up a sort of a quality assurance performance improvement summary. When the residents do it alone, they just try to get through it. It's these massive charts, and they're not paper anymore, but they're even more massive electronically because of the sin of cutting and pasting or copying and pasting. And so the residents only found about 3 errors per chart. But then we tried AI only, and it found 53, but more than half of them were hallucinations, basically meaning they were wrong. And then really this is the point of this discussion is the middle bar is the sweet spot. When you have the AI working with the resident, they were able to say, oh, I missed that, that's right, or no, that's completely wrong. And so that concatenation, bringing the human together with the tool, seems to be something that will be very important for us to build into our workflows. Now let's talk for a moment about a concept of driving care standardization through a nudge unit. What is a nudge unit? It's to push people in the right direction to impose some degree of care standardization. So I'll give examples. Medication safety and stewardship. How many of you still prescribe Benadryl in the hospital for somebody over 75 for sleep? I hope you don't. But the point is some people do, and we need to impose some degree of safety and standardization for medication. Diagnostic laboratory stewardship, so we order the right labs and we don't over-order to decrease expense. Radiology test ordering, 80% of tests ordered at Mount Sinai are stat in the hospital. Are they really stat, or is it just that everyone makes it stat? So creating order out of chaos in terms of better standardization and making the right choices. And I would also add case selection for high-risk treatments or procedures. You have a golden window of opportunity when someone is scheduled for a procedure before that procedure actually happens. And we know that about 80%, let's say, of the risk of an operation or let's say a cardiology invasive procedure, 80% of that risk is known before the person ever gets on a table. So it gives us an opportunity to have a discussion. I never don't want an AI algorithm saying, no, you can't have surgery, but I want an AI algorithm to say, oh, we should have a discussion here and maybe have more advance and review. And already we do a lot of activation of special consults in the background, rapid response teams, stroke, delirium, wounds, falls, violence prediction, and palliative care prediction. But the key is that's getting the right team to the right patient at the right time. It's less controversial because people make their own assessments. So thinking of it like a model, how are we going to bring large language models into clinical care? It's by creating agents. So let's think of inpatient rounds. Of course, the patient's at the center of everything, but think of each of the players and how they will interact and how they will be advised. And so this is the work of the next 10 years, is how we bring this into live action and to have all of our staff see it as a positive, that it's augmenting their care. Sophia, you'll probably hear more about it today, but it is a beautiful example done by our cardiology team. Here in the cath lab, they have an agent that does a pre-catheterization nursing interview. We can't really make it agentic because agentic is supposed to be autonomous, but we have barriers to entry. This is a key point. We have scope of practice issues, we have state licensing issues, so we always must keep in mind that when we build things into our workflow, we're building things into a workflow that is in a highly regulated industry. And we want to do the best that we can. And also, will this agentic agent remove nurses from this process? Absolutely not. We need the nurse to say this is right. Would a nurse maybe be able to do 2 or 3 times as many of these calls more effectively? Perhaps. And so we'll have to see how this plays out over time. But it's an excellent application of the concept of the agentic AI principle. You keep the human in the loop, but you're setting the stage for future iterations with more truly agentic capabilities, which are autonomous. But that'll require change. Let's also talk about biomedical. You are in a world, you're clinical cardiologists. Your patients have wearables. you should and hopefully will be prescribing some kind of remote monitoring, whether it's by a wearable or some other technology, to be able to better monitor your patients. And when they come in, you'll be able to review a lot of data. Some of you may be doing that already. Computer vision in the hospital should be a major advance in safety. And brain-computer interfaces more than neurosurgeons, neurologists so far, but these biomedical advances are truly going to revolutionize. But the agentic AI use cases that I think are more appropriate for clinical cardiology will be improving ambulatory patient access, care optimization, care delivery, with the proviso, again, we don't want poor people only seeing a computer and wealthier people seeing a doctor. The learning health system is something I think we can come back to. Right now it's more of a slogan, but I think we really have to expose ourselves and let large language models learn on ourselves, our behaviors, our patients' behaviors, and all of our data, so that we can start to get that, not just clinical guidance, but also strategic guidance in terms of where we fail to meet the mark. And I would see it as a 24/7 call agent, computer vision in a hospital room, that would help us with safety. It would call a code if someone stops breathing. It helps with communication, food, ordering, entertainment, education, discharge planning, transitions of care, and hopefully educating people that leads us to reduce readmissions. Let's talk about governance for a minute. To be able to bring things in, it doesn't matter if a large language model were free. Building anything into a workflow and working with information technology professionals takes time, and that means money. And so you have to have a thoughtful determination of what is a return on investment. Now, could that be experience, safety, and quality other than money? Of course it could be. And that's exactly where the physicians have to lead. And so I want all of you, as you start to build these tools into your practice, to keep in mind, what is that return on investment for your patients and for yourselves? So it could be decreased mortality, falls, readmissions, complications. As a chief clinical officer, that's my obsession. But it could also be financial gains, such as pharmacy revenue growth, getting more people on SGLT2Is who have heart failure. We vastly undertreat, even within our health system, because we fail to identify the patients. How many people in Mount Sinai Health System have an LDL greater than 190 that are not getting appropriate therapy? Far too many. And we're looking to correct those, and building the expert systems in should be helpful. And that's an example where AI would have a return on investment, both clinically and financially. And then the key point is scalability. Point solutions are expensive. Avoid death by pilot. If all you do is pilot after pilot after pilot, you're destined to fail. You must pick something that you know is going to be ready for scalability from the outset. So how do we make our hospitals and all of your hospitals the safest in the world? So certainly we already are in the world of trying to use predictive algorithms to prevent and to intervene whenever we can to prevent mortality, complications, applying interventions at critical junctures. Let's think about that for a moment. An emergency department admission. Well, you might move palliative care upstream. Think about it. We have a moment there in time where we could have a goals of care discussion. Think about inbound transfers to our hospital from elsewhere. Doing SOFA scoring and building in predictive algorithms to think about whether we're actually doing a patient benefit by bringing them here. Scheduling for procedures and operations, I already talked about in creating stratification and escalation of high risk, and the concept of the nudge care unit standardization. We're currently using a tool. This is not an advertisement. We use AgileMD. I'm sure you can find other tools out there that do that. We currently have about 10 use cases in production, 8 of them in the emergency department. And other things we already talked about, I think, related to clinical decision support. So let me end by talking about the past, the present, and the future. Predictive analytics are very 2017. We were, early in this business. Back then we called it our little big data group, a little bit of a joke. But the predictive analytics, the digital twin, I get sick every time I hear that term. It's so overused these days. And we're going to, at this point, say that predictive analytics are here to stay. They're not that hard to do. The tools are out there, and you can build them into your workflows. electronic health records like Epic. Beware, sometimes they do it really well and sometimes they're still on a learning curve. The present of AI, of course, predictive analytics always continues, but now it's about moving into building AI into workflows to create pathways towards care standardization. We don't do a good job following our own society guidelines. We don't do a good job in many ways. We drop the ball, we fail to have people follow up. We can vastly improve that. And of course, workload reduction. Who doesn't want an ambient AI tool listening to them and writing a note for them? That's obvious. The future, personalization, taking genetic data, imaging data, electronic health record data, wearable data, lifestyle data, and truly moving past care standardization to care personalization. Thank you so much, and I'm very pleased I was able to join you this morning.